Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're plunging into a syndrome that's, well, both urgent and quite elusive. Hemophagocytic lymphohistiocytosis, or HLH. The name itself gives us a pretty big clue, doesn't it? Hemophagocytic, literally blood-eating.
Right. It refers to how certain immune cells actually engulf other blood cells.
And lymphohistiocytosis describes that runaway proliferation of specific immune cells. So you've got your body's own defense system just spiraling wildly out of control.
Exactly, leading to systemic hyperinflammation and potentially multi-organ failure.
It's rare, it's rapidly progressive, and for you, the radiologist or resident listening, imaging isn't just, helpful here, it's absolutely critical.
It truly is. And the core challenge with HLH, the thing that makes it such a diagnostic, minefield, really, is that its imaging findings are notoriously nonspecific. They can look like so many other serious conditions.
A terrifyingly wide array, forcing you to consider this huge list of differentials.
And this is exactly where your expertise, combined with the kind of understanding we want to unpack today, becomes just invaluable.
So our mission today is to be your essential guide through this complex radiological landscape.
Yeah.
We'll navigate the different organ-specific manifestations. We'll look at the unique utility of FDG-PTCT, which can be a real game changer sometimes.
Absolutely.
And give you a clear roadmap for, cutting through those critical differential diagnoses. So let's get started.
Okay. First, let's just briefly set the stage.
Yeah.
What exactly is HLH at its core? Well, it's defined by a profoundly dysregulated, hyperactive immune response, sort of like the body's defense system going rogue. It leads to uncontrolled proliferation of activated lymphocytes and macrophages. And these cells then pump out excessive inflammatory cytokines, pushing the body towards really rapid deterioration, multi-organ failure if it's not treated fast.
And the pathological hallmark, the thing you're really looking for in a biopsy, is that hemophagocytosis itself.
Exactly. Where those macrophages actually start engulfing host cells, red blood cells, platelets, white cells, it's a key diagnostic feature that confirms what's going on.
Okay. And etiologically, how do we usually break HLH down?
Generally into two main types. There's primary or familial HLH, that's typically genetic, seen in kids, usually from inherited gene defects affecting cytotoxic function.
Right.
Then there's secondary or acquired HLH. This can pop up at any age. It's triggered by some kind of robust immune activation.
Like what?
Severe infections, EBV, Epstein-Barr virus is a really common one. Malignancies, especially lymphomas, even autoimmune or rheumatologic diseases can trigger it.
Okay, so what makes imaging so fundamental here? Why is it so critical?
Well, it's because it quickly helps determine the sheer extent of the organ involvement, which can be widespread. It can help pinpoint potential underlying triggers for that secondary HLH we mentioned.
Like finding a hidden lymphoma, perhaps.
Precisely. It guides diagnostic biopsies, helps you target the most affected sites for confirmation. And it's absolutely vital for monitoring how a patient is responding to treatment.
So it's like a constant companion throughout the patient's journey.
You could say that, from the first suspicion right through to, hopefully, recovery.
Okay. So when we talk about the general radiological characteristics, what modalities are we typically using?
We're using the full toolkit, really. Conventional X-ray, ultrasound, US, CT, MRI, diffusion-weighted imaging, or DWI. And increasingly, we rely on FFDG, PET-CT, that's fluorine-18 fluorodeoxyglucose, PTCT. Using these techniques smartly is really key.
So here's that core diagnostic dilemma again, the thing that keeps radiologists up at night. No single imaging modality, no single finding is truly unique to HLH. None.
That's the crux of it.
Its radiological findings are just notoriously nonspecific. They overlap frequently with really serious stuff: systemic infections, widespread cancers, complex autoimmune disease.
There's like finding a single, very common piece of an incredibly complex puzzle.
So if there's no specific smoking gun on the scan, what's the biggest pitfall you see when faced with this ambiguity?
That's a great question. I think the most common pitfall is simply not considering HLH early enough. Because it's rare, because it's nonspecific.
It's not top of mind.
Exactly. So imaging becomes a critical adjunct to the clinical picture and the lab findings. Those sky-high ferritin levels, the alarming cytopenias. As a radiologist, you just have to maintain a high index of suspicion for HLH in your differential, especially with multi-organ involvement without a clear primary cause.
So actively correlating is key.
Absolutely essential. Correlating imaging with the complete clinical picture for a timely, potentially life-saving diagnosis, your role in integrating all that information just can't be overstated.
Okay. That foundational understanding is crucial.
Mm-hmm.
So let's put on our diagnostic hats now and actually see where this rogue immune system typically shows up on scans. We'll start at the top. CNS involvement. You said it's common,
Mm-hmm.
affecting maybe a third to half of pediatric patients.
Yes, and it's often quite severe. It can manifest in lots of ways: headaches, seizures. But the critical insight here, for you listening, is that neuroradiological abnormalities can often be the first and only sign of HLH.
Wow, really? Before clinical symptoms?
Appearing before overt clinical or CSF symptoms sometimes, which means a proactive brain MRI isn't just a good idea, it's potentially a diagnostic imperative. It can totally shift a patient's prognosis.
So key modalities are MRI, CT, DWI. What are we looking for?
Common findings include cerebral atrophy and ventriculomegaly. Those are among the most frequent. You'll also see white matter lesions, typically showing up as increased T2 signal intensity. Other things can include hemorrhage, calcification, necrosis, diffuse brain edema.
And what about focal lesions?
Yes, focal lesions in cortical and subcortical regions, sometimes with variable nodular or ring contrast enhancement. Leptomeningeal enhancement and subdural fluid collections are also reported pretty frequently.
And DWI, how does that help?
DWI, diffusion-weighted imaging, is particularly useful. Restricted diffusion there can indicate active inflammation, or it can help diagnose CNS infections or abscesses that might be mimicking HLH.
And this CNS involvement has real prognostic weight, doesn't it?
It does. Worse outcomes, lower survival. It's truly a silent burden if you're not actively looking for it. We've even seen atypical presentations like ANEC-like brain damage.
Acute necrotizing encephalopathy features.
Right. It just underscores the diverse ways HLH can manifest in the brain. That's why being proactive brain MRI, CSF analysis at initial diagnosis is so critical, even without obvious neurological symptoms. Early detection can really improve the prognosis.
Okay. From the brain, let's move down to the chest. The lungs are another frequent target, presenting their own challenges. About half of HLH patients get respiratory symptoms like shortness of breath, cough. What do we typically see on chest x-rays and CTs?
On conventional chest x-rays, you'll often see bilateral lung infiltrates, pleural effusions. In fatal cases, alveolar or interstitial opacities are common. On CT, especially in kids, look for atelectasis or pneumonia. In adults, alveolar or interstitial infiltrates and pleural effusions, often bilateral, are common.
High-resolution CT.
HRCT might show things like centrilobular nodules, ill-defined consolidation, ground glass opacities, and about half of patients will have mediastinal lymphadenopathies and large lymph nodes in the chest.
And the tricky part here is that HLH can really look like ARDS, acute respiratory distress syndrome.
Absolutely. Clinically, symptomatically, and on imaging. It's also crucial to keep things like tuberculosis and Legionnaire granulomatosis in your differential, as their imaging patterns can overlap significantly.
Okay. Let's shift to the abdomen. You said manifestations here are incredibly common.
Yes, very common. Hepatosplenomegaly, enlarged liver and spleen, is almost universal. Splenomegaly is seen in, something like 89% of cases? It's huge.
So on ultrasound and CT, that enlarged liver and spleen will be obvious. What about the spleen itself? Any specific features?
The spleen might show numerous heterogeneous areas of hypoenhancement areas that don't enhance as much with contrast. Sometimes you see small hypodense nodules, too.
What other abdominal findings should we be specifically looking out for?
Other things to note are gallbladder wall thickening, maybe increased periportal echogenicity on ultrasound, enlarged lymph nodes around the porta hepatis, hepatic steatosis, fatty liver, and ascites fluid in the abdomen.
Okay.
We've also seen nephromegaly, enlarged kidneys, and increased renal cortical echogenicity.
And MRI adds more detail.
It can, yeah. MRI might reveal multiple small and large signal voids in the spleen and liver that maybe weren't so clear on US or CT. Gives you a more complete picture sometimes.
And the differential for these abdominal findings is broad, right?
Very broad. You're thinking about primary liver diseases like acute hepatitis, or a whole range of infections: typhoid, TB, histo, malaria. They all can present with fever, hepatosplenomegaly, cytopenia.
Just like HLH.
Exactly. And then hematologic conditions like leukemias or thalassemias can also cause massive splenomegaly mimicking HLH.
Okay. Finally, let's touch on the musculoskeletal system. You said less frequent, but findings can occur.
Absolutely. Less frequently reported, but they happen. In pediatric patients, we've seen things like periosteal new bone formation, usually in the humerus or tibia shafts, even multiple healing rib fractures sometimes.
Rib fractures, wow.
Yeah, and diffuse osteopenia, widened cranial sutures in infants.
And what about bone complications like osteonecrosis?
That's documented in about a quarter of HLH cases. Affects sites like the spine, pelvis, femoral heads, and MRI, of course, is your most sensitive and specific tool for picking that up.
Now, you mentioned a critical differential for pediatric cases here. That must be incredibly difficult.
It is, and this is a really profound point for radiologists. Those musculoskeletal findings in kids, especially the rib fractures or osteopenia, can mimic child abuse. It requires incredibly careful differentiation. It really highlights the responsibility of correlating imaging with the full clinical context. And of course, joint pain can suggest inflammatory rheumatologic disorders, just adding another layer of complexity.
Okay, now let's talk about a tool that can sometimes really help cut through this diagnostic fog. FFDG PTCT.
Yes, PTCT. It's invaluable because it looks at both morphology and metabolic state. It uses that glucose analog, FDG, which activated cells just gobble up.
So it lights up areas of high activity.
Exactly. It helps identify the extent of disease and, crucially, potential underlying triggers, infections, malignancies, rheumatic diseases, often even before a bone marrow biopsy gives you the answer.
So increased FDG uptake is pretty consistent in HLH.
Yes, it reflects that high metabolic activity of the activated immune cells, the macrophages, and T lymphocytes. But what's really fascinating is its power in differentiating lymphoma-associated HLH, or LAHLH.
Okay, tell us more about that.
Well, patients with LAHLH frequently show significantly higher standardized uptake values, SUVs, that measure of metabolic activity in various organs compared to patients with non-LAHLH.
That sounds like a huge clinical advantage, getting a potential heads up on the underlying cause.
It really can be. For example, the median SUV for the spleen in LAHLH might be around 5.7 versus just 2.0 in non-LAHLH. For bone marrow, maybe 6.9 versus 2.5.
Big difference.
Huge. And lymph nodes, striking 10.6 versus 2.3. The highest whole body SUV might be 12.8 in LAHLH compared to only 4.3 in non-LAHLH. These are statistically significant differences.
So there are specific SUV cutoffs that are pretty accurate for spotting LAHLH.
Yes, an SUV max greater than 5.5 anywhere has shown high diagnostic accuracy, like 92.9% sensitivity, 85.7% specificity in some studies. Similarly, an SUV in lymph nodes over 3.3 or in the spleen over 4.8 are useful cutoff.
But it's not just the numbers, it's the pattern too.
Exactly. The pattern really matters. The incidence of multiple lymphadenopathy with increased FDG uptake is way higher in LAHLH, around 93% versus maybe 36% in non-LAHLH. And multiple bone lesions, seen in almost 43% of LAHLH cases versus basically zero in non-LAHLH in some series. These widespread patterns, especially involving lymph nodes and bone, should really make you think strongly about lymphoma.
And does PET offer prognostic value as well?
It does. High FFDG uptake in the spleen, say an SUV max over 5.7, and in bone marrow maybe over 6.9, has been linked with poorer outcomes in secondary HLH. It reflects how severe the inflammation is.
And conversely?
Conversely, seeing those FDG-avid lesions resolve after treatment is a good sign. It suggests the treatment is working.
But there's always a but, isn't there? A caveat.
Hey, yes, a crucial one. While PTT is powerful, it's not the sole arbiter. High SUVs are suggestive, sure, but the absence of high uptake doesn't definitively rule out lymphoma, especially early on or in atypical cases.
So context is still king.
Absolutely. Always interpret PTT findings together with the clinical picture and the lab data. It's a vital piece, but never the whole puzzle on its own.
Which brings us right back to navigating those radiological differential diagnoses. That really is your diagnostic compass here.
It is, because those nonspecific manifestations demand careful consideration of so many other conditions.
Okay, let's break down some of the most common mimics. HLH can definitely simulate malignancies.
For sure.
It can look like Hodgkin's lymphoma, non-Hodgkin's lymphoma, because of the shared lymphadenopathy, splenomegaly, high FDG uptake.
Right. And specific lymphoma types need watching, too, like intravascular large B-cell lymphoma, IVL-BCL, with its striking intravascular pattern.
Okay.
Or T-cell histiocyte-rich large B-cell lymphoma, THR-LBCL, which also involves liver, spleen, bone marrow, but pathologically looks different. Or splenic marginal zone lymphoma with its specific bone marrow infiltration pattern.
And leukemias too, right?
Of course, various leukemias can mimic the cytopenia and systemic fevers of HLH.
Then there are all the infection that HLH can mimic. Makes the job even harder.
It really does. Viral culprits like EBV, CMV, even acute varicella can look like lymphoma on PT-CT sometimes,
Yeah.
really complicating things. Bacterial infections like typhoid, TB fungal, or parasitic ones like histo, malaria, leishmaniasis, they all present with fever, hepatoselenomegaly, cytopenia, hallmark features of HLH. Even acute hepatitis can share similar abdominal imaging findings.
And don't forget the inflammatory and autoimmune conditions.
No, absolutely not. Rheumatoid arthritis, adult onset, still disease AOSD, they can show prominent FDG uptake in joints or organs, mirroring HLH's inflammation. Systemic lupus, SLE, can present with hypermetabolic lymph nodes and an enlarged spleen, again, overlapping features.
Other conditions to keep in mind.
Wegener granulomatosis, systemic juvenile idiopathic arthritis, and critically ill patients with SIRS, sepsis, ARDS, MODS, they can all present with remarkably similar symptoms and imaging findings.
And circling back to that really tough one, musculoskeletal findings in kids potentially mimicking child abuse.
Yes, fractures, osteopenia require such careful differentiation, a heavy consideration.
So when you consider just how much HLH can look like infections, cancers, or inflammatory conditions on scans,
It becomes crystal clear. You absolutely must integrate these imaging findings with the patient's full clinical picture, their lab results. That integrated approach is truly your best shot at getting a rapid, accurate diagnosis.
absolutely. So to recap then, HLH is this severe multisystemic disorder.
Yeah.
It has diverse, often very nonspecific radiological manifestations across the CNS, chest, abdomen, musculoskeletal system. Imaging is just indispensable for assessing the extent, identifying potential triggers, guiding therapy. FFDG PCCT offers unique insights, particularly for differentiating lymphoma-associated HLH and providing prognostic clues. But ultimately, your expertise as a radiologist in interpreting these complex findings in context is what's critical to avoid misdiagnosis and ensure prompt treatment.
Exactly. And, what's fascinating here is that despite all these advances, the search for even more specific imaging biomarkers for HLH activity continues, biomarkers to really definitively separate it from all its mimics, which raises an important question for you, for all of us, really. How might future advancements in imaging, maybe new tracers, perhaps AI-driven pattern recognition, how might those further sharpen our diagnostic precision in cases like HLH? And ultimately, how will that impact patient lives even more profoundly?